Sorry, I'm getting feedback. Can everybody put themselves on mute if you're not on mute already? Okay, thanks. Again, welcome. It's great to see so many people here today. Thanks to everyone for attending, and also to our fantastic panelists. I know you're going to enjoy hearing from them today. This is our largest convening to date. This was apparently a very popular topic, which doesn't surprise me because it's been at the forefront so much of what I read and what I'm sure you read and hear about from your beneficiaries and constituents, and so it speaks, I think, again, to the importance of this topic. We will be recording this convening today and sending you a link afterward. In addition, we have people that wanted to attend this that could not attend, and we'll be sending it to them as well. In the interim, while we're having our conversation with our panelists, please send your questions through the chat as they occur to you, and we will be happy to relay them, or when we open up the chat, you can ask them directly by just using the emoticon to raise your hand. With that, I'm going to introduce our panelists, Jordan Levy, who is Chief External Relations Officer for Ubuntu Pathways in New York. That's Jordan waving at you. Hi, Jordan, good to see you. Ann McMichaels, who is the brand new Executive Director of Shared Interest in New York. Ann, hello. You can give us a wave so people can identify you. And Sarah Shannon, the Executive Director for many wonderful years at Hesperian Health Guides. I've enjoyed working with Sarah so much over the years, both in the capacity of our foundation and as a former board member at Hesperian. Thanks for being here. I'm going to ask you, and Jordan, I'll ask you to go first to just introduce yourselves and tell us a little bit about the mission of your organization and your interest or work in the area of mental health.
Sure. Well, welcome everybody. It's an absolute pleasure to speak to you all today. It's good to be in a room with this many people, even if it is virtual these days, and see everybody who's interested in covering this topic, because it is so important. Ubuntu Pathways has existed for over 20 years, and we work in the townships of Gqeberha, South Africa, formerly Port Elizabeth, which is in the Eastern Cape of South Africa. And we work on a comprehensive cradle to career model. Our focus is to go deeper into a child and family's life rather than further in terms of reaching numbers of people. And we've been working on this model, as I said, since 1999, and adding layers of different services to help a young person go all the way through. For example, we start with prevention of mother-to-child transmission of HIV, then start working on early years programming, supporting infants, families, mothers, fathers, into early childhood development education. We just finished construction of a primary school, which will lead into a high school, which we're now raising money for. And all the while providing that comprehensive care that we know is so important in everyone's life, but especially in disadvantaged areas, where we look at counseling, medical support, psychosocial support of all kinds. And what we've done in our area is build a hub, the Ubuntu campus, which serves over 2,000 children and their families, as we say, from cradle to career. But the support does not begin and end with those who are kind of the beneficiaries. Our team, our staff is under tremendous pressure while providing these services. As you can imagine, during COVID and these last 3 years, it is increased exponentially when someone is trying to provide these very challenging services because you are dealing with circumstances where you are helping people whose lives are very difficult to maintain in terms of their household safety, their household stability. We think of a child going to school, but a child who's hungry or is not receiving medical care or whose parent is sick will have a hard time learning. And the staff members, the counselors, the nurses, the doctors, the teachers who face this every day are also at home dealing with the same and similar problems, especially as we live through COVID. Mental health, psychosocial support has been a staple in the Ubuntu model almost since the beginning, because we started, our name was Ubuntu Education Fund. We started in education. But we quickly realized when we saw children in school struggling with these issues that we had to add all these layers. And then once we started evolving and hiring more staff and bringing on more professionals, we realized it does not begin and end there. The whole organization needs to be concentrated on positive mental health, addressing these issues, and really getting rid of the stigma of it, and coming to our colleagues and enabling leadership to say, we know people are struggling. It's okay to be struggling. You can tell your supervisor, your boss, that you're struggling. It's not a sign of weakness. Instead, it's a sign of strength that we are coming together and we're going to address these issues. And I can't stress that now, in this time, all of us, regardless of where we are in the world, are facing this, and especially in disadvantaged areas. So I think it's a thread that runs through everything we do. And I can only imagine, looking at the faces and the organizations that are connected here, that everyone on this call is facing similar things. I think you're muted, Emily.
You're right. I was thanking you and explaining to you that I am thrilled to see the passion that you carry for this particular topic and all of the work that you're doing at Ubuntu. Anne, would you introduce yourself and tell us just a brief description of the mission, of shared mission, and your interest and background in mental health?
Yeah, absolutely, Emily. Well, thank you for inviting Shared Interest in our work to be on this call with so many really impressive fellow organizations. And also would like to just thank you for making this a priority as a donor. We don't hear this enough in the donor community. So I applaud you after, Jesus, 20 plus years working in sort of the civil society nonprofit sector. I have to say, this is the first time a donor has called for such a meeting. So I'm Anne McMichael. I am the new executive director of Shared Interest. I was recently named to this post after my wonderful predecessor retired, Ms. Donna Katzen, who founded Shared Interest. I'll tell just very brief, high level kind of elevator pitch on what our work does, but I come to this work from a long kind of professional career in healthcare advocacy, starting with the American Cancer Society, where I worked for about 16 years, and I was part of a leadership team that created the Cancer Society's first global program. So my roots are in healthcare. My passion is in this topic. I can't tell you how much stress and mental health has impacted me personally, has impacted the decisions that I've made to want to invest the rest of my career into. And more importantly, as a Black woman in philanthropy, there's so much of what I think needs to be discussed is about mental health. So I'm very, very pleased to have this discussion. Shared Interest is an organization that was founded out of a powerful anti-apartheid activism. We were at the forefront of, as an organization, stepping up to identify ways that we could help to reinvest into South Africa after the apartheid system was dismantled. And so it was really important that our reinvestment into the region focused on Black and Brown business owners. And so the heart and soul of our mission is to empower Black business owners in the key sectors that are so critical to the sustainability of the region by providing a guarantee fund. Our fund helps to propel businesses to get off the ground, but more importantly, it helps to incentivize banks to loan to businesses that would normally not be on the radar of commercial banks. So after about 27 years of this work, I'm extremely excited to scale what I think is an incredible business opportunity for business owners. Over the years, our work has helped to support more than 2.3 million beneficiaries. We have been able to provide $30 million of funding through our guarantee fund that has unlocked more than $125 million in loans for the businesses that we support. And then importantly to this topic, what's behind all those numbers is the fact that we are going into a highly traumatized market in terms of stress. We're working with business owners that have been considered unbankable. And so there are all kinds of issues related to a silent threat to their businesses that are associated with stress and mental health. So I can't tell you how fantastic it is to be able to have this discussion and to learn from my colleagues on this call. Thank you.
Wonderful, thank you. Sarah, would you finish up for us and tell us about yourself and your work at Hesperian?
I'm delighted to. Thank you so much, Emily. And it's really delightful to be in this conversation. I echo the sentiments that it's a conversation that needs to be had much more broadly. And I'm so excited to be part of this. Hesperian Health Guides is based in, somebody's on a phone and I'm just wondering if you wouldn't mind muting because I'm getting a lot of feedback.
Sarah, I hear some of that's because I've had to dial in, but I've muted myself.
Sorry. Sorry, Emily. Okay, got it. So Hesperian Health Guides is based in Berkeley, California. Our vision is really a world in which people and communities are equipped to achieve health for all. And we've always had a really holistic understanding of health. So that incorporates environmental health, mental health, just a wide array of the kinds of things that really influence whether people are healthy or not. So I think in that sense, some of the issues that Jordan and Anne are working on are totally part of our understanding of determinants of health. And we specialize in producing and sharing easy to understand and practical health information for people to use. We focus on making sure that information is accessible and usable for people in marginalized and low resource communities in particular. And for nearly 50 years, we've been creating practical and how-to resources like our flagship Where There Is No Doctor, along with many other resources. Where There Is No Doctor is recognized by the World Health Organization as the most widely used community health resource in the world. It and our other print publications and our online content is used in 222 countries, and it's available in one or more of those formats in 90 languages. So our materials are really used globally. And again, covering a wide array of topics. But, and I forgot to mention, we're also doing mobile apps. Our mobile apps are in 10 languages and used in 190 countries. So that's, all of these are just ways of getting practical health information to people who are really working in marginalized settings, trying to make health happen in their community. And whether that's a formal kind of delivery of healthcare through a recognized community health worker, or whether that's a community volunteer or a leader who is just trying to organize to improve the health of people in their community. And my path, very briefly, to the work that I do now is that I used Hesperian books during the 80s and 90s, working in Central America, where I was training community health workers and organizing public health programs in a region that was suffering through war and then the sort of trauma of post-war as well. And so I was always really aware of, and that context certainly raised my own awareness of the importance of mental health and addressing mental health and how that intersects with physical health in a very real way. Hesperian's been consciously introducing mental health into our materials for more than 20 years. Where Women Have No Doctor was included a very widely used section on women's mental health that was reproduced and distributed for years by the World Mental Health Organization, in fact, as a really accessible kind of a resource. And we've developed other sorts of materials on mental health over the years, integrating mental health into materials around vulnerable children and working with vulnerable children. But what we're currently getting started on, and my colleague Paula Warby is with me on this call as well, and Paula's really working on this, is we're currently creating and hope to be testing a resource that's going to aid community volunteers and community health workers to promote community mental health in a wellness context, and also respond to mental health distress in the community. So anyway, I'm delighted to be in this conversation with all of you. I hope to learn quite a lot from everyone's questions and from the other presenters. Emily, you're muted, I'm sorry.
Sorry, I'm trying to juggle between thank you for alerting me. I'm trying to juggle between my screen and my cell phone, and I'm not doing a very good job of it. My computer has stopped allowing my voice to carry over to our Zoom meetings, and today was one of those times that it chose to do it. And I can manage that by dialing in through my cell phone, and then you can still see me visually, but with such a large number of people in the meeting, it's creating feedback, and I'm not juggling very well between figuring out where I need to mute myself and when, and unmute myself. Okay, with that explanation, I'll continue on. Why do you think at this time, all three of you, mental health has come to the forefront of healthcare on such a global scale? And why do you believe it's important to add it to healthcare initiatives in the Global South in particular? Jordan, you spoke to this a little bit in your introduction of yourself. So, Anne, in particular, since you're thinking of adding such programs to your ongoing efforts, and Sarah, with your experience in the field, if you'd like to relay some of your thoughts.
Sure. Well, I mean, I think everyone on the call can agree that COVID-19 has, of course, exacerbated pre-existing challenges with doing our work, advancing our programs. So I think that the urgency now more than ever is critical. At Shared Interest, what we are looking to do is to, through our new model, identify new and more impactful partners and partnerships that will allow us to provide the kind of support services that our businesses need. Our businesses are deeply stressed. We are working in an environment where the banks are particularly conservative. And so it's important that we are able to work and advance our model in a way that is respectful of the lived experiences of our beneficiaries. They will be absolutely key to a COVID-19 economic recovery in South and Southern Africa. And so we're eagerly interested in partnering with organizations like those on this call that have unique contributions to a solution that will allow us to understand the particular challenges of entrepreneurs, particularly women entrepreneurs, that are having to shoulder so much personally, with family and with having to be the chief medical officer of their households, as well as trying to conduct businesses outside of the household. So I think there will be, once we hopefully ever, and when we emerge from COVID-19, we'll have a much healthier respect for the role of addressing mental health as a priority across the board, in the nonprofit sector, in the for-profit sector, in the government sector, because I think it definitely requires a multi-sectoral approach. But I think the real call to action is to make sure that we are all individually creating safe, brave places to have these kinds of conversations. I'm a leader of a small staff team, and I know how stressful it is to work in this environment. I know how stressful it is to work with me as a new leader. And so I think it's important that we take the time to make sure that we're breathing and that we're acknowledging that this is a particularly stressful environment for us to be trying to advance our missions, and that it's affecting us personally, professionally, and certainly it's affecting our beneficiaries in the Global South.
Thanks, Anne. And I think Jordan also did a really great job of sort of underscoring the ways in which this pandemic has really exacerbated underlying and existing mental health challenges and crises. Maybe my contribution to this question, Emily, might be to talk a little bit at kind of the global policy level and the sort of big picture stuff, although I do think that probably everyone on this call understands the degree to which this is a crisis. But even before COVID, WHO was ranking depression as the single largest contributor to ill health and disability. And they were ranking anxiety among the top 10 causes of disability across all regions. So this isn't just focused on the Global South, but I think what is really relevant to the Global South is the disparity in terms of access to services, where you can measure it in one way with there's an average of 2 mental health workers per 100,000 people in low income settings versus 70 mental health workers per 100,000 people in higher income countries. Now, I don't actually think 70 mental health workers is sufficient. I mean, and the WHO's definition of who is a mental health worker is actually pretty broad, but you can sort of see where some of the challenges are. That's a really enormous disparity just in terms of access to formal care. And that's not addressing the barriers that people that are, I think, much more intense in lower resource settings around barriers to care in general that have everything to do with income and resources and transit and distance. And then there's stigma, which is just a huge issue that we can climb into, I suspect, later. But those are just as an overview, those are some of the barriers that are much more exacerbated in lower resource settings and become much higher barriers, in addition to literally the total inexistence to access to mental health workers who are trained. So that's, and that creates a huge challenge, but it's also really an opportunity. And the World Health Organization has been recognizing both the challenge and the opportunity. And the opportunity that I think we all represent part of is this kind of idea of redirecting resources towards community-based mental health services and community-based mental health work. I think that's the space we're all operating in. And that's a huge space, but it is a redirection of effort because it seems impossible, although a laudable goal, to try and actually create highly trained professionals that could be working in every community. But that's maybe not even the right approach to take. Similar to healthcare in general, our model has always been the idea that community-placed actors are often the best equipped to identify a health problem, and in this case, identify a mental health problem, and provide culturally competent, really realistic, grounded support, as well as referring to a network of more skilled providers when that's needed. So I'd love to sort of explore more with in this conversation about ways to really sort of build out and talk about that kind of community-based mental health approach. I think just the point about integrating it into existing healthcare, actually, that's another one of WHO's recommendations. And it just makes sense. If a nurse or a midwife is the person who's seeing an isolated new mother, she's going to be the one that's going to notice that there's clearly signs of postpartum depression. She's going to be the person, she or he, that nurse or midwife is going to be the person that has the most access to this isolated person and can provide support. A community health worker may be best equipped to understand that a description of pain in a certain way is very locally grounded as a somatic sign of anxiety and depression. You know, I mean, just as a few examples of why actually community-based health workers are probably the best equipped to be part of, and maybe the most logical kind of frontline mental health worker as well. So I'll stop there, but I'm looking forward to this conversation to sort of deepen that topic.
Thanks. I'm going to come back to what you said in just a minute. I do want to get, because I think you've touched on something very important, and I have a couple follow-up questions for you on that. I do want to give Jordan a chance to add any thoughts he's got regarding how this topic has become of such importance, and or why it's taken so long for us to really realize we need to focus on this.
Well, Anne and Sarah have done a tremendous job of framing this and cited the real statistics and the real situation, which is that this existed long before these times, although it is very clear that COVID has increased exponentially what's going on. But I think in direct response to your question, Emily, I think it has to do with those who control the conversation, because it existed, but it was off the radar of those in true privilege who have the power to control this conversation. And it's only now that we're suffering this massive global mental health crisis that we all say, oh, this mental health thing is a real problem. And imagine if, you know, not only in my privilege, I'm facing these mental health challenges. Imagine if the conditions were much stronger. And as Anne and Sarah have pointed out very surgically, these conditions are a pandemic in themselves. And, you know, you talk about the hidden threats. They shouldn't be hidden, but they are. And that's why we have to call them that. And only now are those who control the narrative. You know, Anne started out by saying this is the first time in 20 years she's had this conversation. And I also commend you for having it, because where has this conversation been, as you're asking? It should have been there, and we should have recognized it. But we don't really want to look at it, because when we design interventions for other things, we want them to be 100% effective, 90% effective. And, you know, when we start unpacking what it actually takes to have an effect on someone's life, it's so much that it's costly, it's time consuming, and it's difficult. So we're only able to attack one thing at a time. And the conversation doesn't get to the nuances. We have to have these forums where we can actually have a real conversation. And you know, we need people that are open to the conversation. And Emily, when you and I have talked before, I've said to you, I'm glad you're asking me these questions, because I don't usually answer them. Usually I get the 2-minute elevator pitch and I'm done. And it's good when we talk about these things, but it is a long conversation, and there are no magic bullets. And what you're going to come up with at the end of this conversation, in my opinion, is just that it's a long road ahead. Doesn't mean there's opportunity. There's actually huge opportunity. I think Sarah touched on some of it, but it's really, some of the funding opportunities might be huge right now because people are paying attention. And when that starts flowing, you might be able to let the people on this call, as an example, have great ideas, creative ideas, and the on the ground staff, start really getting the funding and the time they need to make these things happen.
If I can jump in.
Thanks for adding some really good salient points there, Jordan. Particularly around the idea that people in the global South have not had the opportunity to give voice about this issue, and even people in the global North, there's always been something of an attitude of suck it up and deal with it, be tough, be strong, be a man, be a strong woman, what have you. But so it truly is, as you noted at the first, a kind of a second global pandemic. But going back to some of the issues that Sarah was mentioning regarding barriers to completing this work, Sarah, I wanted to ask you a question, which is, how important do you think general public knowledge of mental health and the capacity that you can seek out assistance for this, and what good mental health even really is? How important is general public knowledge to achieving success in this area?
Well, super. I have a lot to say on that, but I did want to underscore 2 points that Jordan just made before we transition to that topic. In terms of why is it hard to get attention on this issue, and perhaps why it's been difficult for funders to get behind it. And I think one is the point Jordan made, which is there is no silver bullet. It's really attractive to try and find that simple single intervention that's going to make all the difference in the world. And mental health is messy and complex and doesn't have a single silver bullet. And it takes a long time to actually make change, because you're having to address so many different underlying conditions and issues and variables. It's a hard topic to work on, and I'm afraid that it's a hard one, therefore, for philanthropy to fully be able to get its hands around because of that. So just to say, I really want to appreciate that the West Foundation has always sort of appreciated and understood an integrated approach and the long-term approach to its projects, and give you a little special call out for that, because it's unfortunately all too unique. In terms of community and public awareness, it's essential. And I do think that this is actually one important component of a community mental health approach. And it's one way that community leaders and community actors can really help move the dial. It's not the only intervention, but it's an important one, because community information helps to raise awareness in general that this is an issue. It helps people begin to identify what are signs and what are indicators, as well as what are ways to promote good, healthy mental health. Good mental health. And it's central to one of the key challenges of mental health work, which is the stigma attached to mental health distress. And so we know from all kinds of other examples on all kinds of other topics where stigma is a major issue, that awareness raising is really critical. And awareness raising in a way that makes it clear that this is not blaming anybody, that everybody is at risk, that entire communities are at risk, and greater risk for mental health distress, and some of the factors that can be made to make change. So I actually think, and we believe it's a cornerstone of good community mental health work, is that kind of broader awareness throughout the entire community. And I'd love to hear more from Jordan and Anne about ways in which, in the communities that they're working, that's actually happening and how that's helped move the dial.
I would love to hear from Anne and Jordan as well as to what barriers they perceive while we're kind of circling around this topic of barriers. what do you perceive as the barriers? And also, Jordan, I know you have had a successful mental health component to Ubuntu's problems for at least the last 15 of your 20-year history, because that was one of the earliest things we helped support, was getting those in place. So I'd love to hear how you've also overcome some of those barriers.
Well, I think as far as Ubuntu's approach, it was the problem itself that drew us into the quote unquote solution or the intervention. As I said, we were called Ubuntu Education Fund. We were founded by a 19-year-old young man and a school teacher from the community. And they just wanted to help. They really had no idea what they were doing outside of some educational interventions. And
that makes me feel so much better, since we funded them in their first few years of operation.
Well, we needed somebody to believe in us, right? We
dodged a bullet there. We funded them and they succeeded.
Take it till you make it. But in any case, it was impassioned, and it was something special. But it probably wasn't all that effective, except for getting to the next level. But it was the learning, because you go into a school situation and you start providing some sort of educational supplementation, which was really what it was. And when the academic results don't improve, even though the instruction is good, you have to ask yourself the question, why? And then you start to understand, oh, what's going on at home is totally trumping anything that's going on at school, the conditions that are faced. And the interventions start there, and you start to say, well, what could we do differently? And then, as I said before, it's just adding layer upon layer, and a lot of it's trial and error. And that's where it came from. We wouldn't have survived in any effective way without it. And then, of course, I keep going back to those who are delivering the services and those who are on the ground. And I lived there for 10 years and was on the ground, but still, of course, with my privilege, didn't have to deal with the same thing that my colleagues were dealing with, but I could see it, at least, and gain some understanding of it. And there's no way I could have coped with it and done my job. And you have to start building. So we built an internal leadership development program early on, which I know is very rare for nonprofits, because we're not supposed to spend money on overhead, right? And God forbid there's anything that anybody could call overhead in our budget. But it's, and maybe you don't have to call it overhead, maybe there's ways around that, but the point is, providing careers, not just jobs, because people want to know what's going on in their future. They have kids to raise, they have providing health benefits, okay, where you can see a professional psychologist or something like that, providing counseling, and providing the services that we all would want as well. And of course, we didn't start out that way. We couldn't afford it. We had to fight. And it's getting that going. It's getting everybody's buy-in. It's stakeholders on the ground. It's making sure that, and also, of course, getting people to access the services, because there's stigma even in accepting help. And so it's, again, so multi-layered. But if I had a message on this call, is when we get to the funding side of things, it's unrestricted funding or funding that allows for it. Those things are all too rare in our sector as well, and allowing organizations to respond to the needs and layers. Sarah and Ann have talked about it. It becomes an onion that you have to peel back all these things, and those on the ground are best served to understand that we have to give them agency to develop these things effectively. And as Sarah said, we don't know what it's going to be, but it's not. I'm not going to design it in New York. And that's what we have to know. Maybe I can help in some ways. I have some expertise, but I'm not going to design it in New York. And we have to give organizations the power to do that.
So, Jordan, that was interesting, because we work with an MFI that works in Latin America in 7 countries. And they're women, they work with women, obviously. The women have actually come to them and demanded women's healthcare services. So they've started providing those as a part of the community centers they build. What you're telling us is this was more from an educational perspective of teachers viewing students and saying something's wrong here. And instead of we need to adjust our education model, we need to look at what might be the root causes that they can't concentrate or absorb, et cetera. And then it became an internal process to offer that as what you do, as you described earlier, the depth of services. So that's interesting to me, because one of the questions I had, and maybe Anne could address, if any of the beneficiaries at Shared Interests have asked for mental health or even general health services as a part of your assistance to them.
I was going to say, I think a big barrier, and I think Sarah and Jordan may have touched on this, is stigma. There is not, I think, yet the license for us to be talking about this in an upfront way. Oftentimes it will come to us indirectly. In fact, Martha, my colleague, and I were just talking earlier in a catch-up meeting, and she shared with me that one of our beneficiaries committed suicide. And so, that's when you're not having conversations. That's when there isn't the license yet for a business owner to share that they're struggling and that their stressors are getting to the point where they cannot see a way forward to living the next day. And I fear that COVID-19 is going to open yet another window into a shut opportunity, because we're not having these discussions. We're not having these discussions in the U.S. the way that we should. I do not at all subscribe to projecting or assuming what's happening in a country that I don't currently live in, but I suspect this is an issue that's deeply shrouded in shame, and that is deeply shrouded in the inability to talk about it. So I think really addressing the fact that this is still such a deeply stigmatized issue, and figuring out the culturally appropriate ways for us to acknowledge that as donors and as partners from the global North, we want to be allies and support a stronger conversation around this issue. And so I think the other piece of this is the ways in which we require reports to be done on our work. Impact is going to look a different way. And sometimes the impact that we have is not going to fit neatly into a report. And so, we had a really difficult conversation with the beneficiary the latter part of last year. And she was particularly stressed because she had a business that was being threatened by the COVID-19 challenges. And she, I think that we all suffer from not having the right resources at the right time. And so it would have been so helpful for me to have had at my fingertips a way for me to connect her to resources and connect her to support in a way that really is respectful of where she is in her journey. So I think there's a lot that can be done around connecting to resources, sharing stories, making sure that we're being really intentional about insights. I think that, this is a time for us to be really understanding the impact of, mental health on all of our businesses and collecting those insights, because I think policymakers in particular need to understand this issue, and need to be thinking of ways that it can be more of a policy priority, because I think this is just a challenge that will continue to stifle progress. And then lastly, I think that the way in which we even talk about economic recovery and economic success is so decoupled from health. We're looking at sharp numbers, financial numbers that don't nearly tell the story of how much it takes to really have a whole and healthy society. And so I wish that we could figure out ways to de-silo philanthropy, because I shouldn't have to feel like because I work in health or because I work in economic justice, those are two siloed issues. And I think, Emily, you asked as one of your questions, is it mission creep for shared interest to be looking at mental health as part of our mission? I mean, I would think that I would be a creep if I didn't prioritize mental health in our work, because it absolutely influences everything.
I so hear you on that, and I agree with you. For the record, just so everyone who didn't get to read the questions I sent out to everybody knows, my full question was, do you have any concerns about donors and or investors in your work worrying about you doing something they would consider mission creep? And I think that's a good explanation. Something, when you and I had our first conversation together last fall, I told you that part of our mission is the alleviation of the poverty of hope. There's many kinds of poverty. You address economic poverty. Sarah addresses health poverty. Jordan, you kind of address community holistic poverty and the work that you do. But what we look at in funding all of you is addressing the poverty of hope. And I had not really thought of it this way, but when you exist in a poverty of hope, that very much is a mental health issue. And when you have no hope that anything you try is going to help you, that is a mentally depressive state. And that's really the factor that then keeps you from taking the initiative to do anything to solve your own problems or give voice. So one thing that might be a great resource for you is when Hesperian is able to finish its book that's specifically about mental health. But I know, Sarah, you've mentioned you have other materials of things like a part of the book Where Women Have No Doctor and a couple of other books. But can you tell us a little bit about what the mental health book is going to be about, and then how Hesperian sees that it will be using communities for assisting healthcare workers and building better community knowledge of the road to better mental health?
Well, I'm delighted to, and I just want to appreciate Anne's comments about the silos, both in philanthropy, but also in how we often are therefore echoing those same silos in our work. And I think that mental health is maybe really difficult because, but also the opportunity, the unspoken opportunity. There's huge synergy between physical health and mental health. There's huge synergies between education and childhood development and well-being and mental health, and huge synergies between economic development in a community and mental health. So that silo issue is just, I can't, underscore it enough. And Anne, thank you for speaking to that so clearly. And in terms of what we're trying to do, Hesperian, just to sort of recap for those of you who don't know our materials, they're designed to be really practical, usable for people without necessarily a lot of formal education, but they're not simple either. And they're often used to train or as resources for frontline health workers, be they midwives or community health workers, nurses, as well as people who pick up these resources and this information because they're interested in just doing something to help their community. And they may be a school teacher, they may be a business leader, they may be somebody else entirely. And for us, they're all health promoters. And that's, I think, one of the interesting challenges, because I think almost anybody in a community can be a mental health promoter. And maybe that's our vision with these materials, is to create a resource that can help those mental health promoters do their work. So what Hesperian develops all of our materials in collaboration with communities that have real experience with the issues, with the problems, and folks that are trying to tackle those issues already, so that their lived experience and their knowledge and what they've learned already is part of what we capture and then share out to others. So we're currently working with partners, and I should say this is a very early stage in the project. So we're also really looking for partners to work with on this. So I just want to put out the call to everybody on this call and people you might know. But my colleague Paula and I would just be delighted to hear more about anybody interested in helping us on this. But we're working with, for example, partners in Nepal who have some experience with trying to do mental health promotion, particularly for women's health. We're working with a group in Botswana that has been doing postpartum depression work with teen mothers and trying to train nurses and midwives around just that one piece. We're working with a group in El Salvador that does violence prevention work and works with survivors of both partner violence and doing sort of gang prevention work as well in urban settings in El Salvador. We're working with folks that are providing sort of safe spaces for immigrants, people who are literally en route and migrating, and often what's motivated them to have to migrate in the first place, and may have been a great deal of trauma, and they're still living it, and the process and the experience of migration is actually increasing that kind of traumatic experience. And so creating safe space and short-term support, even if it's only short-term. Those are a few of the kinds of partners that we're working with, and what they're doing is helping us really construct some practical resources, practical information that can be used to train anyone who's trying to promote community mental health, giving them tools to identify mental health problems, at least the most common ones, as well as be clear about what might be a mental health emergency, how to deal with that and respond to that, while also ideally referring people. I mean, that's the other piece of this equation, is you need to be able to refer people to better care, which needs to be built out too. But that pathway to support that Anne was talking about, I think this is what we're trying to do, is build resources that give people that pathway. So also helping equip somebody to actually run a support group, form and run a support group, because that's a relatively low cost intervention that can actually do wonders. Do community organizing that might actually be mental health promotion. Recognize that that a community's self-esteem actually has some bearing on an individual's self-esteem and vice versa. And I think like the work that both Ubuntu and Shared Interest do are sort of really go in that area, I think, where that kind of collective self-esteem and individual self-esteem can really matter and create stronger mental health throughout. So those are just some of the examples of the topics that we're addressing. We're really trying to equip people, particularly focused on some of the more commonly recognized and understood mental health conditions like anxiety and depression and responding to trauma. While recognizing that mental illness is perhaps beyond the scope of what a community-based program can do, I think understanding what mental illness is as well and working to destigmatize all of that is really essential. So that's like a key underlying component of all of it. just as an overview. So we are currently beginning to work on this with partners, trying to collect their experiences, trying to get their input on the scope and the focus and the content. We'll be developing it. We'll be doing early testing on this resource. We do iterative testing to get feedback from folks that are both working on this topic already and folks that want to introduce it into their work and integrate it into their work. So again, that's an open invitation to everybody. And that's kind of where we're at, Emily. You know, I'll just say that resources for this are uniquely difficult to find. Financial donor supported resources are uniquely difficult in the field of mental health work. We've experienced that the majority of funders who are funding want to support or feel that it's a really pressing need to support mental health services provided by mental health professionals. And I can't argue against that, but that isn't going to reach most of the world. And it's not going to reach the people that we all work with. So that's I think our challenge.
It sure is. I'm going to also ask some questions in a different direction now, because how many people here, you can put up your little wave emoji if you want to tell me how many people here today have some interest in adding a mental health component to the work that they are doing. I see 1, 2, 3, 4. Anyone else? 5, there's Megan. Hi, Megan. 6, 7, okay. So a goodly portion, about half of you today, have some interest in trying to do that. So I want to be sure we ask some questions that might help give you practical advice. And so I'm going to throw over to Jordan and say, I think I know how you will answer this, but can mental health elements be successfully added to existing programs? And if so, because I think I know you're going to say yes, what preparations should organizations make in order to do that?
Sure. I mean, the answer is 100% yes. I think some of the steps, would be obvious in terms of who to hire and bring on and that type of stuff. But what I could say that I think is interesting or helpful is about context, and ensuring that you've consulted and that it's driven locally and based on local context, because we can't presume what the problems are. And we it depends upon where you're sitting if you're going to be able to analyze what is causing these mental health problems, where do they result of, where are they coming from, and therefore provide any sort of solution. And really, it's a simple thing of being locally driven in your programmatic development. And hopefully the model that you're working off of is naturally that, and therefore this would be an extension. But if you find that you're driving the solution from kind of a macro perspective or an outside perspective, I would definitely try to critically analyze that and understand how you could start a little bit more from the bottom up and drive the solution from there, and understand the context first, and then bring in those who understand it. I think my colleagues might be more qualified to talk about the details of how to design it specifically, but that is what I could offer.
Thank you. Sarah or Anne, do you have thoughts you'd like to add to what Jordan just shared?
Our experience comes a little bit more from folks that are already doing health promotion. So many times it's simply starting a conversation at that local level about mental health, and a conversation will start. People see it. You know, it's maybe understood different ways in different cultures, but people do see mental health distress. And I think folks that are working in health see that maybe even more, but I don't think that that's a unique health perspective. But I've certainly seen health programs where they've just started the conversation among the providers, be it a group of community health promoters or midwives or nurses, and just sort of talking about what mental health issues they're seeing. And the sort of the answer of how it can be incorporated into their work may flow even naturally, because despite some of our siloization, folks on the ground don't silo this quite in the same way. And I think that's actually, again, a strength that we can build on as we're trying to integrate mental health work into our work.
Thanks. Anne?
Yeah, I don't have much to add because I think both Jordan and Sarah covered it nicely. The only thing I would highlight is the importance of prioritizing the unique stressors in the workplace, and the need for CEOs and leaders of sort of startup industries to be equipped with the information that will allow them to lead with mental health as a priority. I think that particularly with young entrepreneurs and business owners in particular, they are uniquely challenged, and oftentimes I don't think they feel they have the license to talk about mental health and stress. And so I think there's a huge opportunity to use them as, I think what was suggested is, you can be a health promoter without necessarily being in the formal mental health space. I think we need to have more health promoting champions in this work. And then lastly, I think, openly acknowledging that systemic racism has its own unique stressors that must be acknowledged. And so I think the conversations around racial justice and economic justice provide important avenues to be talking about mental health. So I think those are really important observations as well.
I'm glad you brought that up, Anne, because one of the thoughts that had occurred to me while you all have been talking is that element of inherited genetic stressors. And we hear that talked about in movements such as Black Lives Matter here in the US, but overseas that also exists, and for longer. And so it truly is something that has, at study after study has shown it exists, and that it has to be dealt with, and it has a very direct impact on mental health. I'm going to wrap up just because I want to, this is a deep topic, and we're really just hitting the tip of the iceberg today. So I hope you all will come back and have for follow-up conversations down the road. But I want to ask you a question that's related to funding, which, if you could pick one, and I mean just one thing that's the most important thing that you think donors need to understand or have knowledge of in considering funding for mental health, what would that be? And I'm going to start with Sarah on this one.
Okay, well, I may have already said this because I do think that, well, two things come to mind. The first is really believing in a community-based model. Despite this getting endorsed from World Health Organization, I feel like the philanthropic community that's being supportive of mental health is still not giving credibility, I think, to this idea that community-based actors can actually be one of the most important ways you can address mental health. So I think that might be my first message. The second that I've been contemplating is I'm thinking back to how gender became more mainstreamed in philanthropic work. This dates me, but like during the 80s. So what would it look like if sort of everybody needed to think about, okay, and how will you add on a mental health component? Just like, and what synergy would there be with mental health? Just that one single little like question of, is there some synergy on mental health that might just help all of us see, wow, the community economic development work I'm doing, I could just do this one little piece more and there'd be all this synergy around promoting mental health, or whatever the topic is, women's health work. That's the dream, but I do think at least an appreciation and a valuing and giving credibility to community-based actions is essential.
Thanks. And Anne, what would you add to that? What's your most important thing you would like a donor who's considering giving to shared interest for mental health program to know?
I think it's revolutionary. I have to give some thought to that because I think this is some pretty revolutionary stuff. It would be huge if the donors and the philanthropic community came forward with a strong statement and pledge that this was going to be a key ingredient or focus or priority of their giving. That would be huge because I think that so much of what gets done gets funded. And if donors and if the philanthropic community were to demonstrate such commitment by coming forward and really sort of weaving this into requests for proposals and, just making it a very upfront, very transparent, publicly acknowledging statement, that would be huge. And I think that could definitely help with driving impact around this issue.
Thanks, Anne. Jordan, we started with you at the very beginning, so I'm going to wind up asking you on the last question I've got. What is your answer to that question?
I can't really say something very different than what my colleagues here have said, because it's,
and that's okay. It's just ask you what your one thing was.
Yeah,
so
yeah. No, I can.
You don't have to reinvent the wheel.
Right. I can maybe echo it and hopefully strengthen a bit, but they nailed it. I mean, and when Anne was talking earlier about redefining impact, I was smiling from ear to ear because I know she's probably struggled with it for all these 20 years and beating her head against the wall, because I know I have and my colleagues have. And revolutionary is a good word, radical is a good word, because my opinion is that philanthropy in general, not everybody, and not some of our funders, not just West Foundation, but some of our other funders, some of them are on the right track. But the truth is, in my opinion, the philanthropy sector is so far off from where they need to be, it would have to be revolutionary or radical change to get it right. It won't be incremental, a little bit of a 10% here or something. It's got to be a radical reimagining of how they fund. And I just want to go back to Anne's impact point, and again, not really change it, but just hopefully echo it in the sense that it's how we measure it then, because if you're going to fund it, you can't expect 100 units of something to come out of it in a year. There is no way to measure it that way. I can produce something because that's what I do for a living. I know how to say it, but it's not that tangible. Think about somebody going to see a mental health professional for a year. What would you ask the psychologist to write down at the end of the year that proves that the money they spent was well spent? It doesn't. That's not how it works. That's not how it's done. So, it's more of a conversation. I have no problem with accountability, by the way. When I'm talking like this, some people say, well, you have to be, of course you have to be accountable. You have to have a conversation about how you're spending that money and what you're providing as an organization. Of course, you're providing quality mental health services, but you can't just say it's gotta add up to 100 widgets or units of X, and therefore you get more funding or you don't. And really 1 year is not a cycle that's going to change anything. So That's really my input, and I think, you know, it's just to echo what Sarah and Ann have said, because I think we're all a little frustrated, but you know, I think there's also a tone of optimism today, because it does seem like something is evolving, and something is changing in the way we look at this. So hopefully we're on the right track.
Thanks, and I totally agree with you, Jordan, and I'm thanking you because you've just given me a great idea for another convening sometime on reimagining philanthropy, which again could be multiple days and convening over multiple sections of that very thing. I'm going to add my own thought to this question, which is, I think funders need to realize that this is a very holistic topic that touches on every other kind of work that gets done in the global South. It doesn't just affect healthcare, but it affects education, as you obviously are a great example of that. It affects economic programs such as the one that Ann runs, and other types as well. It affects your ability to give voice. It affects ability to make decisions on your own. It affects the success of all the other programs. So there should be no excuse of, we don't fund that. We only fund education programs. Well, this is to make your education programs fully successful, you need to have this element to it. So as a funder myself, that would be the key thing I would like other funders to realize, along with every other thing that you all have mentioned. So again, we'll sometime, again, even for the three of you to come back and have a conversation on simply addressing that kind of topic. That's something that could be of great interest. And then we'll save correcting philanthropy as a whole for some other time. We've got about 15 minutes left. I'm just gonna ask each of you very quickly, do you have any final thoughts that you didn't get to bring forth on this subject today vis-a-vis this conversation? You can just jump in. I'm not going to call on you.
Well, I'll quickly jump in. I think that we're extremely excited at Shared Interest to be reimagining our portfolio of businesses that we will be looking to support. You know, particularly excited about ways that we can start to look at ways to thread health into our work and make it more of an explicit area of economic opportunity. So we're really excited about ways of strengthening our work and scaling our work with health as a major driver of our model and what we hope to see in increasing our impact.
Perfect.
I'll jump in. I'm glad to see you know, all these people turning up for this conversation again. Not being able to come together for some of these things is frustrating. I'm glad there's such an interest that people are driven to even come and participate in this in a virtual way. It's encouraging to me. And while Emily certainly said it well, that we're only, you know, scratching the surface of this, I appreciate a conversation that does move this forward, and it is inspiring to me. I you know, 3 years ago and before, there was times where you get together with people from different organizations and talk about these issues, and there was more forums for that, and it always filled my tank a little bit. And it's been a long time since I've done this, and it's inspiring to hear Ann and Sarah talk and remember how much energy is going on just outside my little bubble. So this is good for my mental health, if that means anything. But in general, we've covered some of the key issues here, and those issues could be unpacked with hours and hours of conversation. But I think we've hit on some of the key things, and that is that this needs some reimagining. this needs to be a bigger driving point in how the sector itself looks at what we're attacking here, because we have to get back down to fundamentals. We figured this out a while ago with early childhood, where a lot of us like ourselves started with older young people, and then we realized, oh, if the first 1,000 days doesn't go well, you're falling way behind, or even before that, the pregnancy, you know, all those things. Why aren't we getting there with mental health? Why aren't we realizing that the foundation of human development, we have to be healthy and stable? Let's get back there. And once we do, I think we'll all catch on and be like, oh, of course, that's the fundamental. But sometimes our sector has a hard time, and many sectors have a hard time shifting that way and really recognizing what the foundations of our work are. But I'm happy to be on a panel with other organizations that are already way ahead of that. I've been it's been nice to hear you guys speak, and I love the work that you guys are doing. Thank you.
Thank you, Jordan. Sarah?
Well, just to echo, it's delightful to be in a conversation with folks. And I would actually really invite anybody that is interested in doing work or is doing work, integrating mental health into your work, regardless of what work you do, to let us know, because we'd love to learn from that experience and incorporate that to the degree that you wish to in the materials that we're developing. So that's just another call out for partnership on this. I think that this conversation has really underscored the way in which I think every one of us can promote and work on promoting mental health in our work. I think that there's an issue we didn't touch on that I just want to put a pin in for a future conversation as well, which is one of the issues that I believe is really challenging about mental health is many of us have strayed away from it because we don't even know how to talk about it. There's so much stigma. And that's one big, huge challenge. The other is recognizing that there are cultural differences in interpreting mental health, and yet there are some globally understood mental health issues, and learning how to sort of balance cultural humility and letting communities lead on this. And at the same time, recognizing that there are some globally, universally experienced mental health issues, and there are some things that can translate and be adapted and localized that can work. I think that's a really hard place to get to for all of us. And I think that may be one of the barriers that I didn't speak to before, that I think is one of all of our barriers in working on this issue. So just wanted to maybe add that to the ongoing agenda of future conversations, but mostly to appreciate the fact that, in fact, to be in a room with so many people that are really appreciating the holistic approach that's necessary to really address this is really a pleasure. So thanks so much.
Thanks, Sarah. I was very heartened by the attendance today as well, and the attention everyone has given to this topic. And we will, partly in with your request that everybody participate or continue to, if they are willing to participate. I think what we'll do is try to put together maybe an email circle of people who were involved in this conversation, to find what further discussions you'd like to have around this topic, to see if there are ways we can all assist each other in not only assist Hesperian with this work, but assist each other, answer questions, be supportive group for exchange of ideas, etc. So we will definitely follow up with this and be in touch. I want to leave a couple of minutes. We can go over by a few minutes, but I want to be respectful of everyone's time to make sure people do get to ask questions they may have been holding back. I only see one in the chat, which was a question. I wonder if we are projecting some of our North American and European anxiety onto the rest of the world. In my interactions with Central Americans, they seem less anxious in the midst of the pandemic than we are. I wonder if they are more equipped to handle the anxiety of this pandemic. They tend to be more communal and less individualistic, more history and practice dealing with other infectious diseases, hardly any vaccine resistance, and a strong community worker network, something the US lacks. I agree that the Global South could use more resource for mental health. I also think we could learn a lot from them in dealing with mental health. And there's a lot there's a good deal to what was relayed in this question, particularly regarding what I think are lessons we always can take from the Global South and import to the Global North. But just in general, because and your work is in Africa, Jordan, your work is in Africa, do you think that's different from the Global South, or are there issues maybe in the Global South not related to the pandemic that are stressors, just as that are just general stressors in the Global South at large?
Well, I want to be very specific.
I'll take a quick stab.
Oh, go ahead.
I think that, I was just going to say, you know, a big stressor for us that we're dealing with at Shared Interest is the systemic practice of discriminating lending. You know, that's the big stressor. It's steeped in you know, sort of racialized banking practices, but that is a stressor. You know, really addressing who is unbankable is a big stressor that doesn't, I think everyone has shared, there's no easy solutions to this, but certainly the stressors around not being able to access capital that will help to provide a sustainable livelihood is a big issue. And so I think those are the things that, you know, COVID-19 just further exacerbated, but these were sort of pre-existing conditions that lead to their own forms of unique stress on beneficiaries, on local societies, particularly rural groups. So I think there's some real opportunity for us to be thinking of this holistically.
Yeah, all I can
Thanks.
say.
Go ahead.
Yeah, in response to that question is, it's a great point, and it leads back to context. I am only speaking from the context of a very specific organization, a very specific community. My experience, and to be very clear, my experience is I haven't been to South Africa during the pandemic because I couldn't get there, as long as I've been away from South Africa in 20 years. So that's first and should be acknowledged. But also, when I talk, I'm talking about, you know, I do speak to South Africa every single day. I speak to South Africans, but I'm speaking to South Africans who live in a very specific community, in one specific place in South Africa. I cannot speak to Africa. I am not even that knowledgeable about the rest of Africa. I can speak to a specific place in South Africa, and I can say that this community has been decimated by COVID-19. South Africa as a whole has been, and this community on the Eastern Cape has been decimated by COVID-19. The anxiety is high, the economic and social effects have been disastrous. But that's it. That's all I can say. That's about that community. That's what's happened. That's what we're dealing with. But I wouldn't certainly deny that other places, you know, wouldn't necessarily have the same experience.
Just to pop in here, I mean, I do think that working in mental health requires us to have cultural humility. Let's be honest, the US, we are not leaders in global mental health. And I think we all know that. So I just do want to underscore the experience from the Global South. Certainly that's where we're taking our lead in, particularly the experience in the Global South with folks that are doing community-based mental health work. Again, the US has much less experience with this. So I think this may be one where we can and I don't mean to say that's not happening with wonderful groups on the ground in the US too, but I just think as a recognized approach in the US, we're not there yet. So just want to appreciate that comment from the listener, from the participant today. And just to note that I think different communities all over the world are experiencing the stressors of COVID in many different ways, but there has generally been, I mean, just from what we're hearing from partners in diverse areas all over Latin America, Asia, and Africa, there, you know, lockdowns are creating all kinds of different mental health stresses on different populations, and it manifests in different ways, but increased suicide rates in Nepal among rural women. It's sort of there. It's just really visible in different kinds of ways in different communities. And I think, again, that points to our challenge of working on mental health, because it can be seen in so many different lights that it's very hard to globalize. But I appreciate the observation and comment.
You're muted, Emily.
Emily, we're not hearing your wrap up.
Emily, you're muted.
I didn't unmute, did I? Yeah, I apologize. Sarah, thank you for those wonderful remarks. And I appreciate all of you coming up with an answer to that question. I see a lot of people thanking us for today, but I didn't see any other questions in the chat box. If anyone else has a question, you're welcome to just unmute yourself and ask it at this point. It is 4:30, so I want to respect your time, but we could probably stay another 5 or 6 minutes if people have questions that we can try and answer, including myself with my limited knowledge of this topic. You're better off asking our panelists, but I can do what I can do if you have a question for me. I'm looking at the chat, and thank you for all the kind thank yous. Appreciate that. Well, I think I'm not exactly, no one is coming forth with that question they've been burning to ask all for the last hour and a half. So I'm going to say in closing, thanks to everybody for attending, but in particular, a huge thank you to Anne and Jordan and Sarah for coming and sharing their time, their knowledge, their talents with us. It's been really wonderful to start on a journey of exploring this topic with you. And we will be sending out, per the usual, a survey. So if you would please fill it out and return it to us so that we can continue to refine our convenings. This is only our third one. So we're still very much in a learning mode ourselves on this. And so would appreciate your feedback enormously. And we will also be sending out a link for viewing of today's conversation. Please feel free to share it with anyone else that you think might benefit from the information, particularly your donor networks. If you found this at all valuable, please share it with your donor networks, and they may tell them they should only listen to this part, or from 5:47 to 6:51, but you'd like them to hear that, and invite them to other convenings, because